Good afternoon. So, if somebody that is here don't want to be or don't accept to be their image or voice to be recorded, please switch off your camera and switch off your microphone. So, good afternoon to everyone, and thanks for being all again here for this Beamer project webinar. Today, we're going to meet some projects on adherence field. So we have three speakers, Daniela, Katerina, and Cynthia, that are going to present some projects and some outputs of their projects on adherence field. So in this webinar, the questions to our speakers can be asked in the end of each presentation. So we have 20 minutes of presentation and 10 minutes of discussion. So you in the meantime, if you have questions to the speaker, please put them in the chat of our platform. So to start, we have with us Daniela Figueiredo. Daniela is researcher in the Center of Health Technology and Services Research is a big research center, Portuguese research center with different locations. One of them is in University of Porto and also in University of Aveiro, because she is professor in the School of Health Sciences of University of Aveiro. She is leading a project called Together We Stand that aims to promote adherence in end-stage renal disease patients through a family-based self-management intervention. Let's know more about the project. Daniela, the floor is yours.
Thank you, Elisa. Good afternoon to all of you. It's a pleasure to be here. I would like to thank especially Elisa Costa for the invitation to be in this Beamer webinar. I will share my presentation. Let me see if you can see my presentation. Is that okay to you?
Yep, that's perfect.
Yeah. Okay. So thank you. I will start to tell the history, the story of this project, of this Together We Stand project, promoting adherence in end-stage renal disease through a family-based self-management intervention. So, what is it? This is a research project aiming to develop and to evaluate the impacts or the effects of a psychoeducational family-based interventions for adults in hemodialysis and their family members, their family caregivers. This is a granted project that started on July 2018 with a 36 months of duration, but because of the COVID-19 pandemic, it had 12 additional months to add it. So we are near of its closed. So who we are? We are an interdisciplinary research team composed by researchers and health professionals of different scientific fields, from psychology to education, to medicine, nephrology, physical therapy, and from various national and international entities. So, well, I'm the project leader, the principal investigator of this project, but I had other colleagues and other members of the research team, like my colleague Oscar Ribeiro, a PhD student, Helena Souza, and other colleagues such as Professor Constança Paul, Professor Elisa Costa, Fernando Ribeiro, Alan Kirstensen, and others. And it involves other entities like the University of Porto and other research units from Portugal and from other countries like the US. So, and why? What motivated us to to develop this project. Despite that chronic kidney disease is rising worldwide, Portugal is one of the European countries with the highest prevalence of people in hemodialysis. And hemodialysis treatments demand several radical changes in the life of patients, because they have to adhere to dialysis sessions in a dialysis center 3 times a week during 4 hours each sessions. They have to make amendments in their diet, and also they have to restrict their liquids consumption, as well as they have to care their vascular access. They now have to practice physical exercise, and this leads to the burden of treatment, and often leads to psychological distress to these patients, but often to their family members who provide the bulk of support to these patients. So we know that these psychosocial impacts have also some effects on the adherence of these patients that we know, and we know that non-adherence rates to all these kinds of behaviors have been reported as high as 86% worldwide. So at an international level, several psychosocial interventions like cognitive behavioral therapy, educational interventions, self-management interventions have been developed to promote adherence in kidney failure. However, only modest results have been found on adherence. For example, on medication adherence, on fluid, on diet, and also only modest results have been found on the psychological well-being of these patients. And maybe this is because this kind of interventions are patient-centered and fail to consider the importance of family relationships and family support as determinants of the adherence. So the big question is that we posed is that if we involve a family member in hemodialysis treatment, giving them also psychosocial support, is this enough to boost patients' adherence and enhance both patient and family adjustments? But we have no available evidence to sustain this recommendation of family-based interventions as part of hemodialysis treatments. So what were we going to do was to develop, implement, and evaluate the family-based self-management interventions for adults undergoing hemodialysis and their family caregivers. And how to do it? What have we done? Well, in the first, we thought to do this by through 3 main tasks. The first task was the exploration of the educational and emotional needs of both patients, family caregivers, and diets of patients and family caregivers. We also want to know what were their expectations and fears and perceived barriers to a psychoeducational family-based interventions. And we conduct this exploratory study through qualitative approaches and basically through individual and dyadic interviews to patients, to family caregivers, and to diets of patients and caregivers. This task was very important to run a second task, that was to develop the intervention and test its feasibility, acceptability, and preliminary effects in a pilot study. I will share with you some results of this task 1 and task 2, and then the main study was to redesign and assess the effects in RCT with a 6-month follow-up, and to provide and to evaluate the effects of intervention in clinical outcomes, but also in self-reported psychological outcomes. We would like to compare the differences between family-centered, patient-centered, and usual treatment. So for the first task, the exploration of educational and emotional needs, the results have been disseminated elsewhere, but the main results were that the patients and families would like to know more about their condition, their treatment, like very objective strategies to control fluid intake, to manage their diet, also to care of their vascular access, but also they would expect to have some emotional support and develop some coping strategies to deal with the challenges and the emotional challenges of their disease and their conditions, as they consider these conditions a we disease and not just only a patient's disease. So the family considered it as a we and a condition that affects all the system. They also want to know more about how to effectively communicate and interact with the healthcare team, the renal care team. So this information was very important for us to develop the intervention that was pilot tested, and again the results were published and disseminated, and the pilot test was 6-week pre-post study with 6 diets of patients and family caregivers, and combining quantitative but also qualitative methods to evaluate its effects. And I must say that regarding the feasibility, we had a screening rate very good of more than 90%, but we had the eligibility rate very small, very modest, about 18%, because most of the patients that were screened, they had cognitive impairment, or they had restrictions in their mobility, or they had other diagnoses besides kidney failure, like cancer, for instance. We also had a low consent rate, mainly because these patients felt burdened by their treatment, and to participate in a psychoeducational program or intervention represents more burden for them. And some of them mentioned that the lack of transportation for the dialysis centers was a motive or a factor for not being present and to not accept to participate in the intervention. But however, we had 100% of completion rate, and we had some promising results, because anxiety symptoms decreased significantly after the intervention, and depression symptoms decreased after intervention. There was not a significant statistical difference, but a moderate effect size. And regarding the patients, the interdialytic weight gain, it also decreased after the intervention with a robust, a very good effect size. Then we were starting the main study after this pilot study, and we were all surprised by the COVID-19 pandemic. So we thought, well, we had in Portugal 2 lockdowns, and following the recommendations, the international recommendations and guidelines regarding hemodialysis patients that are high-risk patients for COVID-19 infection. Well, all the dialysis clinics were closed for external members. So we were thinking, what can we do to continue this work? So that's why we thought to explore the impacts of the pandemic in non-COVID-19 patients undergoing hemodialysis, to explore among these patients, but also among their caregivers, and to explore the feasibility, acceptability, and preliminary effects of an online psychoeducational interventions for patients and their family caregivers. So, for the first two aims, the results have always been disseminated. I can tell you that there were some decrease in serum albumin levels, and also a little increase in phosphorus levels in patients before the lockdown and after the lockdown. And for caregivers, for instance, this means additional challenges as more care responsibilities and fear of contaminate their family patients, their loved ones, was very present in these participants. So we are now trying to conclude the results of the feasibility, acceptability, and preliminary effects of these online psychoeducational interventions. So we developed an online psychoeducation intervention, which we named of Connected We Stand. We create our own web page, and we developed three online editions between March and December of 2021. We have 6 online synchronous psychoeducational sessions led by 2 health psychologists, and this was combined with the synchronous models with different professionals and experts in different contents like transplantation, vascular access, formal support and services, or living well. We had only 27 participants, and the assessment was conducted with self-rated instruments plus focus group interviews after the interventions. We found many barriers. The main ones were dissemination and adherence to this kind of online interventions that was combined with poor digital literacy of our main target, and maybe this is related with the low educational, socio-education levels of our participants. Well, where are we now? We are analyzing data. We are analyzing the quantitative and the qualitative data, and we are starting the scientific writing. We are in this process. And what do we expect? Well, we expect to provide sustained evidence about the effects of family-based interventions to not only to maximize patients' adherence to treatments, to hemodialysis treatments, but also to promote patients and family psychosocial adjustment, and eventually to prevent against the erosion of family support. What are the potential impacts? Is that we don't have these answers, but eventually family-based self-management interventions as a component of hemodialysis treatment could be cost-effective tool, or maybe become a regular component of hemodialysis treatments, or lately it could be a way to increase patients' eligibility for renal transplantation. So this is all this project is conducted with a wonderful team. These are some of the faces behind. Of course, I don't have the faces of our patients, of our family caregivers, but these are our academic colleagues. And thank you once more for all your attention. Thank you very much.
Thanks a lot, Daniela. Very good presentation. So I will ask to the attendants to put questions to Daniela. I will start with a question, and I will expect that others come to question to you. So, Daniela, this is an intervention that you develop but is intervention to the family. Okay, so what for us is quite innovative, because in fact, usually when we develop intervention for a patient, so you put this this intervention are for dialysis patients. However, my question is, do you think that other types of patients could benefit of these familiar interventions? Or you think this is only important for dialysis patients as the characteristics of the disease?
No, I don't think so, because, well, my interests includes these bidirectional links between chronic disease and families, because we know that a chronic disease have impact on family systems and family functioning and dynamics can affect the person with a chronic disease. So we have some evidence, and we have conducted here in the University of Aveiro this kind of interventions in other chronic conditions, like for instance neurological conditions or respiratory conditions like COPD. And we have several benefits, not only for the patients, but also for their family caregivers, because, well, when the family caregiver or the family members, or those who are close related and provide the bulk of support, they don't serve only as a resource for the patient, but they suffer the impacts of the chronic condition, the impacts of the psychological state of the patients in their own. So they also need support, and they have a very important role also in supporting the patient, in encourage the patients to adhere to the recommendations. So we are not isolated in our room or in our space, but we leave the healthcare settings and we are at home with our family, most of us. So it is important to also tackle family as a whole and not the patient as the only unit of intervention. So I think this is applied for every kind of chronic disease and at different stages of disease or different stages of individual development. But we see this mostly for the infancy and for the later life, not for the adult in the middle, in their 30s and 60s and 70s. So it's kind of, I think family-based interventions are still in their infancies for adults with chronic diseases, yes.
Thank you, Daniela. Cynthia, do you want to pose a question?
Yes, I'd like to thank you, Daniela. That's great work, and I congratulations for being able to do the work during COVID, because in Australia, all clinical work completely stopped. I mean, for 2 years, we stopped the research essentially. I've also got a question about sort of the relative influence of the families to maybe other sources. So we did a little bit of work looking at the relative influence that people with asthma got from different people. And we found that more than half the influence on their behavior was not from healthcare professionals, but they also talked to people who had the condition, and they, so I don't know, what do you think sort of long term how will this kind of all come together, do you think? You'd leave it with the family, or would it then be some sort of integrated for this whole network? How do you think it might go in the future?
I think that, first of all, the role of some kind of health psychology in dialysis settings, it's very important, because this is a very demanding treatment. Dialysis does demand attending dialysis sessions, but also other kinds of behaviors that patients have to change. This has a great impact on their mental state and in their family's mental state. So I think that it would be very important to have in renal rehabilitation, to have a component related to this emotional support of patients and their family members at the beginning of dialysis, when they start to do dialysis. Of course, I think this preparation should be earlier, before they start dialysis, but we know that withdrawal rates are in the first 18 months of starting dialysis. And we also know that most of the patients that withdraw dialysis are depressed. They are really, really depressed. So I think that dialysis care as a whole, or dialysis rehabilitation, as you wish, should have a component related to provide counseling, psychoeducational support to both patients and family members. Should be a component of the hemodialysis or dialysis treatment, and of course some follow-up sessions should happen in the long run. I think this would be important, but this is my academic view, and only our academic view and our academic perspective.
Thank you.
Thank you.
Thank you, Daniela. Any other question from, Katerina?
Yes, thank you, Daniela. I'd like to ask whether you have a plan to measure adherence to the intervention.
Yes, we had the adherence to the intervention with some clinical, bioclinical data, self-reported instruments, and then the times that they went to the sessions. So the effects of adherence, we have analytical data that can show that, like phosphorus, albumin, intradialytic weight gain for the patients, and then psychological self-reported outcomes like symptoms of depression and anxiety for both patients and family caregivers, but also self-reported adherence for patients. And then we count the adherence to the psychoeducational sessions. Yes, of course, the absence and the presence in all the sessions.
Thank you.
Thank you so much. Any other question, or we can move to our next speaker? Okay, thank you so much, Daniela. Fantastic presentation. Okay.
Thank you.
Very good.
I will have to leave. I'm going to run my classes, so have a nice webinar for all of you. It was a pleasure.
Thank you, Daniela.
Have a nice work.
So now our next speaker is Katerina Kassavou. I don't know if I pronounce well the word, but which is a behavior scientist from University of Cambridge. She's working on the development and evaluation of intervention to support adherence to medication within primary care using face-to-face and digital delivery models. Katerina will talk about the program on adherence to medication to support adherence to antihypertensive medication. So Katerina, the floor is yours, and thanks again for taking part of this webinar. You are mute. You are mute.
Sorry, yeah. Thank you very much for inviting me. So, I'm going to be presenting a program grant funded by NIHR to Professor Stephen Sutton from the University of Cambridge Clinical Medical School. That is an intervention that has been we have developed with a group of colleagues who I will be presenting later on. It's a behavioral intervention in primary care and aims to support treatment adherence to patients prescribed medications for hypertension. It is a randomized clinical control trial. So I'm going to briefly present how we went about into developing the intervention, and then I will be presenting some preliminary evidence of implementation and outcome evaluation. High blood pressure, we know, is a leading risk factor for cardiovascular conditions and major cause for morbidity and mortality worldwide. However, half of the patients with hypertension, they do have high blood pressure. Adherence to prescribed medication is one way to support and manage the health condition, but also to reduce high blood pressure. Healthcare providers into primary care are the first point of contact, and they have a very important role in supporting these patients take the tablets as prescribed and manage their health condition. However, consider the time constraints in primary care. The time is very limited and also very expensive. So currently, we don't have very effective ways and proven ways in primary care to support treatment adherence to non-adherent patients with high blood pressure. What we have, a group of people and myself, we have developed the PAM intervention, the program adherence intervention. It's a two-component intervention. It's been facilitated remotely by a practice nurse using a video link or a telephone link as part of usual care consultations. That could be medication reviews or blood pressure checks. The patients have been provided with a 5 minutes behavioral intervention, and they've been signposted to a digital component. The digital component involves a text message or a smartphone app, and participants during the 12 months of the digital component of the intervention, they can switch from the text message to the smartphone app. The intervention is highly tailored. The participants at the start of the intervention, they provide responses to questions measuring some determinants and underlying mechanisms of behavior change. And based on the responses, they receive tailored behavioral advice about medication adherence. The advice is simply reminders. It could be simply reminders like the medication they've self-report forgetting to take. But also, and most importantly, dynamic behavioral advice regarding the underlying mechanisms of behavior change and the reasons that they might forget or they might not take the medications as prescribed. The patients can select the time they receive those messages, but also they can change the settings in terms of the frequency, duration, but also the content of the messages based on the revised prescription. So how we develop the intervention? To develop the intervention, we use behavioral theory. Behavioral theory drove the intervention development part of workstream 1 and workstream 2 of the program. We use behavioral theory to disentangle complexity in terms of the various components which they may interact, the multiple groups and the organizational level to target for the intervention, the different and multiple processes that they are interlinked into delivering, but also into receiving the intervention. Those are the multiple outcomes. The clinical measurements in our case was blood pressure as a primary outcome, but also the behavioral outcomes and the organizational outcomes, considering that this digital intervention within the UK primary care setting. So there were elements regarding digital health as integrated into the current usual care. And why we use behavioral theory? We use behavioral theory because it provides a very comprehensive description of the observable, measurable, replicable components, mechanisms, and outcome of an intervention. How we went about into developing, we used consultations with stakeholders, commissioners, academics, patients, healthcare providers. We conducted literature reviews with meta-analysis to identify what other interventions, effective interventions, have been consisted of, and what they did actually measure, so we can link the components of the intervention with the measurements of the intervention. And also we conducted interviews with patients and the healthcare providers who are the front line of receiving and delivering the intervention, in terms of their perceptions about the reasons that their patients might not be adherent to the treatment, in terms of the healthcare professionals, but also patients' challenges into taking their tablets as prescribed. We got insights from experts, from health economists, from GPs, from health psychologists. We are, as a group, behavioral scientists, so we led the evidence synthesis into developing the intervention from multiple perspectives. Importantly, we have developed and we have implemented pilot and feasibility randomized control trials as the key method to test the acceptability of the intervention recommended. So this might seem like a very complex picture, but actually provides a very simple answer to a very complex question: how the intervention will bring about change into the intended effect. In the first level, it's a very brief, it's a description actually of how we do expect that the intervention will bring about at the patient level. And at the second one, it is a description of how we do expect that the intervention will bring about change into the health professional level. For example, we identify the theory that will underline the intervention mechanisms, how the intervention will bring about change into the patient level. What would be the strategies, what would be the content of the messages of the VBI intervention, of the very brief advice facilitated by the practice nurse, of the text messages or the smartphone notifications, how these are mapped into the different delivery modes, what would be the component of the VBI and what would be the component of the text messages and smartphone notifications. And most importantly, what are the behavioral objectives, how we will measure whether the intervention achieved its intended effect. What are the main behaviors that will indicate that the intervention was effective in terms of the implementation? Like we would observe that patients enact self-regulatory strategies, that they have effective communication strategies into resolving concerns about the health condition and adherence, that they take actually in a proactive way the medications as prescribed daily, that they book and attend the consultations with the healthcare providers, that they effectively engage with the healthcare professionals, they collect their prescriptions as prescribed, as their prescription as expected from the pharmacy or the GP. And so these are we specify what are these behavior objectives that we will measure to find out whether the intervention actually achieved an intended effect. And if these are satisfied, then we would expect that the intervention will, that patients will increase daily adherence to their prescription, and also that will lead to a reduction in systolic blood pressure. In some of our patients, they have comorbidities of type 2 diabetes or high cholesterol, so we do also collect measures of bloods to measure glucose levels and lipid profile. On the other side of the coin, it is actually the healthcare providers. We develop an online theory-based training in order to enable healthcare providers facilitate very brief behavioral advice as part of usual care. And bear in mind this, that this kind of very time-restricted consultation the nurses have to implement in primary care. So at the preliminary stage of the intervention recruitment, we identified that there's not only the time constraint, but might be also beliefs about the reasons of why people are not adhering to the treatment. Healthcare professionals' beliefs about people's non-adherence to treatment, their abilities and the skills that they have to facilitate behavioral risk appraisals, to enable the patients form intentions to take the tablets as prescribed, but also professional norms, considering that this intervention is about integrating digital components as part of the face-to-face and usual care consultations or remotely delivered consultations in our case. So the online training aimed to address those concerns, actually then provide the skills and enable healthcare providers to facilitate very brief behavior intervention as part of the usual care. And we had also some behavioral objectives to measure the efficacy of the training and to enable the participants, in that case, the healthcare providers, but also linking it with the broader cost effectiveness program theory, because this is very specific to effectiveness part of the intervention. How this will provide impact into the service provision, but also into the NHS cost. How we will evaluate the intervention? What are the plans of evaluating the intervention, and also the effectiveness and the cost effectiveness of the intervention? Currently, we are at the stage of intervention evaluation. We have completed recruitment. So I will be briefly describing how the intervention effectiveness has been implemented so far, and how we measure effectiveness and cost effectiveness. Based on the work package 2 and 3, the conclusion was that we will be performing an individual randomized control trial as part of the usual care, and that would be the design to evaluate the effectiveness of the intervention. And that meant that we would have half of the participants in the intervention group, which was visual care, and half of the participants into the intervention group, which was visual care plus the PAM intervention, and half of the participants into the control group, which is the comparator group, which is usual care, treatment as usual. In terms of the outcome measurements, the primary outcome is blood pressure, systolic blood pressure at 12 months follow-up. That is measured with remote blood pressure measurements posted to participants, and they've been recommended to measure the blood pressure for a week and obtain 38 blood pressure readings, and post the blood pressure measurement blood pressure device back to the research team, who extracts the data from the monitors as an objective measure of blood pressure. We also obtain urine samples as a measurement of objective measurement of medication adherence. Patients are provided with a urine sample kit, and they provide urine sample at baseline and 12 months follow-up for detection of antihypertensive medication in the urine. That detects whether the patient has been taking the tablets on the 48 hours before the urine sample test has been collected. To evaluate the effectiveness, we will test the change in blood pressure measurement, systolic blood pressure, associated with, together with the changes in biochemical medication adherence at 12 months. The data will be adjusted for baseline values and healthcare providers only. In terms of the preliminary findings and the implementation, we have engaged 84 practices, primary care practices in England and Wales. We have provided training to 84 nurses, 3 hours online training and face-to-face with the researcher. We have recruited actually 580 patients with hypertension and high blood pressure, randomly allocated to interventional control group, 15% participation rate. Bear in mind that these people are those hard to reach. Our recruitment strategy was aiming to recruit patients from different demographic areas and indexes of multiple deprivation. In terms of the completion, we have a good completion rate in terms of the blood pressure measurement. In terms of the medication adherence, is to provide a urine sample remotely. We have 78%. And in terms of the cost effectiveness analysis measurements, those are reported by the patients, not those collected by the practices, is 93%. So patients are willing to provide measurements for cost effectiveness analysis. And these are completing questionnaires about their attendance to hospitals, to primary care, costs relating to their healthcare in terms of managing their blood pressure. Some preliminary findings, all our participants, they are approximately 65 to 66 years old. Most of our participants are male, but equally female. The blood pressure at baseline for all of our patients was raised. After the online VBI consultation, the intervention group patients had slightly lower blood pressure, but not considerably. The medication adherence in terms of self-reports, all patients, they do self-report during the self-decision-making consultation that they have been missed some of their the days of taking the medication as prescribed. And in terms of the biochemical medication adherence, it seems that the intervention group participants have slightly better adherence after the consultation with the practice nurse. These are some preliminary evidence from the process evaluation. To perform the process evaluation, we collect data from digital log files to find out how patients are using the digital components of the intervention, but also during the VBI, because practice nurses, they log into an online web page. I'm sorry, I'm concerned about the time. As these are some of the preliminary evidence in terms of how patients have been engaged with the intervention, and it seems that most of our patients, they have a good engagement rate with several different components, and especially the intervention behavioral mechanisms by which we expect the intervention will bring about change. And that is also the program theory guides the intervention evaluation, the process evaluation, so that we have evidence as to whether the intervention has been effective, what components they have been effective, and how this can be replicated into wider scale. So to conclude, the key messages from this program so far is very important to develop a behavioral program theory at the very beginning of your program or intervention, build the right mix of expertise, evaluate how the intervention will bring about the behavior change, why the intervention program worked or did not work, for whom and under what circumstances, so that we can build so that we have the evidence to have replicable interventions, effective replicable interventions for, in our case, primary care. So in terms of our group, these are, and I would like to thank the collaborators and actually those who are leading the intervention development and evaluation. Professor Stephen Sutton, he's the PI and director of the program, but also we have Richard Manus from University of Oxford, Queen Mary, Southampton, King's College, UEA, and also the co-sponsors, the Cambridge and Peterborough Clinical Commissioning Group. I guess I'm still, thank you very much for your time and for inviting me into, sorry.
Thank you so much, Katerina. The pleasure, of course, is ours, and it's a pleasure to have you here, and very good information that comes from you to us. So I will put one question before I give the floor to Laura, and I'm going to put you one question. When we are talking about, and particularly in hypertensive patients, we are talking about long-term therapy, and as you are a behavior scientist, I'm going to ask you if you think this kind of intervention are sustainable in time, because you know it's very difficult to change behaviors. And now we put an intervention, we evaluate during a short period of time, but what you expect it to happen after?
Yeah, that's a very good question, because we have noticed that there are also some patients who might not use the intervention as regularly as we expect them to use. And we want to find out whether that is an indication of engagement with the intervention itself. Because there might be some patients that they manage to self-regulate their behavior for after using the intervention for 3 months or 6 months intervention. In our case, it's 12 months intervention. The challenge is in to sustaining the change and facilitate and delivering this intervention is that technology is updating from one day to another, and we are always running behind the technology, to be honest, because people are using and installing apps one after the other. But our point of view is not to get them to use the digital intervention, to be engaged with the digital intervention, but actually to take that as an opportunity to engage with theoretical ideas that will help them self-regulate their health condition and improve their behavior in terms of adherence. So even though the technology is going faster than we do anticipate that by using the technology that it's available to them in every day, because they install these apps into their mobile phones, that they will pick up some of the components that might be effective in supporting the self-management. Of course, this is to be adapted into primary care should it be effective and cost-effective.
Thank you. Laura, going to pose a question?
Yeah, thank you. Thank you so much, Katerina. That was really interesting. Thank you. I have one question, and maybe you may have mentioned this, so I apologize if I missed this. And I was wondering, so we have as the outcomes, we measure the adherence, and of course we have the blood pressure, but we have this whole, as you said, you're starting with a theory of what the factors are that affect this. Is there any way, or are you measuring sort of what it is that makes people adhere or not adhere? And if you do, how? So that, like which of those factors that you hypothesize are the ones that will, improve, or, adherence are really the ones that are working?
Thank you for the question. We do obtain measurements for all these components. For example, we use questionnaires for the theoretical determinants, and we also obtain measurements of engagement in terms of, in that case, engagement is conceptualized as frequency of using the intervention. But also we have audio recordings of the consultations with healthcare provider that we analyze qualitatively, interviews with patients and the healthcare providers after the completion of the intervention. So we anticipate that the quantitative evidence with the qualitative will be synthesized to provide a response to this question. Fantastic, super, thank you, that's great. Thank you.
Cynthia?
Well done, Katerina. It's great work and very beautifully presented to us to understand the different components. As I was listening to all this, I was wondering about how important is it to actually deal with the comorbidities and any issues that the patient has with other comorbidities as they're being treated for taking medication for their hypertension, because for them, it's not just one disease at a time, it's just whatever life presents them with. So what are your thoughts on that?
Yeah, thank you very much for the question. In clinical trials, it's kind of a linear effect you would expect, because the outcome, we do specifically measure adherence to antihypertensive medications only. Although the urine sample analysis detects adherence to glucose, to diabetes type 2 and cholesterol medications. For the patient's point of view, it is perceived, and it is actually experienced as it is a systemic approach, not only about the patient self-managing, taking 10 or 20 pills per day, but also the support that they've been receiving by the healthcare provider, by the family, and the wider system itself. So these are some of the insights that we do expect to obtain from the interviews from participants. The more holistic approach, and how an intervention, if not this one, we don't know yet, how an intervention could address those components if they haven't been addressed by this intervention.
Okay, thanks a lot, Katerina. And now we have finally, thank you so much, Katerina. It's a great presentation and a great experience that we have opportunity to listen from you. Very good. And now we have Cynthia. Sorry, Cynthia, I cannot pronounce your
yes, that's all right. Bosnik and Tisovic.
Okay, which is head of quality use of respiratory medicines group. She's also president of respiratory effectiveness group, executive director of area, chair of pharmacy on area. So is engaged in a lot of scientific group, and she will share with us some insights related to adherence that coming from some international projects, particularly to PIFotal and the MASK study. So, Cynthia, the floor is yours.
Thank you very much. Thank you very much, Alicia. And it's really a pleasure to be here with international colleagues. And I think that what you're doing with BEMA sounds really exciting. So good luck with that. I look forward to following it on. So, while we're sort of just getting ready, I've taken a slightly different approach because a lot of work has been done in adherence in the respiratory field. And so what I'm going to do today is I'm going to put together the picture of the respiratory patient, the way in which that patient presents to the healthcare professional, and what we know works and what we know, what we're not sure works, and how digital technology and mHealth is being used to try and solve those problems. In respiratory, I think many think that when we're using digital inhalers, it's going to solve all the problems, but I'm not 100% sure, and it'll be interesting to see what you think of all that. Now, to start off with, I'm going to cover, essentially when I talk about these chronic respiratory conditions, I'm talking about asthma, COPD, and allergic rhinitis. And I just wanted to put the treatment pathways for these diseases up for you just as a snapshot, because the important thing to get out of all of these, now I think you can see my cursor if I move this, what you can see with asthma is it follows a stepwise approach. If you look at COPD, it once again sort of has a stepwise approach. It has a pathway. And if you look at allergic rhinitis, once again, there's sort of a building of treatments from the baseline treatment. The really important thing to notice or take home from all of this is that the clinician's decision to change the medication and to give different advice depends on the patient-reported outcomes and the symptoms and the story that the patient tells the healthcare professional about their condition. Even though lung function measurements are supposed to be part of diagnosis, certainly for asthma and COPD, in primary care, this very rarely happens. So it really depends on what the patient tells their healthcare professional and the assumptions of what they're doing with the medication that has been prescribed. So what does the day in the clinic look like? And I should point out that I'm actually a clinical pharmacist by training. And so I very much approach this from the perspective of a patient coming into a clinic or seeing a patient. And what do we see? If we have a look at a snapshot of people with asthma, which is at the top, people with COPD, it doesn't matter where those patients are coming from. Unfortunately, a low proportion of them have got good disease control. So we can assume that the red color, the red bars, a majority of people have got suboptimal disease control. When we look at allergic rhinitis, we know that only about that most people that come into the pharmacy now in Australia, you can get most allergic rhinitis medications in the pharmacy without a prescription. We know that most people who come into the pharmacy have moderate to severe disease, and only about 65% of them have even got a doctor diagnosis. And 70% of them approximately self-select their own medication. Now, whether they have mild allergic rhinitis or moderate to severe, by the time they've left the pharmacy with their medication, you can see only at the most about 20% of them are on the right medication. So many people have poor disease control, and they potentially, where they have a choice, are selecting their own medications. The other issue that we have with all these three conditions is patients often have very poor perception of their illness. So in this COPD study, which looked at patients reporting their symptoms, about a third of them described their symptoms as being mild to moderate, despite them being too breathless to leave their house. And 90% of them admitted that they weren't completely honest with their healthcare professional. With asthma, once again, we find that there's a mismatch between patient perceptions and their disease control. With the guidelines control down here, patient perceptions here, about 40% of patients think that their asthma is well controlled, even though it actually isn't. And then we have adherence, where there's so much data on patient adherence to their respiratory medications, and studies show anywhere between 8 and 70%, but we sort of think it's probably about between 60 and 70% that have poor adherence. And when we look at interventions that improve adherence, the blue bar is those where we see adherence rates after an intervention. Unfortunately, we know that even though adherence improves, it drops off after time. And this particular study looked at patients who were on the more moderate to severe end of the spectrum, because you might think, well, probably most people who have asthma, as an example, have mild disease. And that theoretically is the case. And so maybe we think, oh, well, it's perhaps the milder patients that have got poor adherence, but it doesn't seem to matter what level of severity the patient has. This study looked at patients who had medication that was at the moderate to severe stage of disease. And as you can see here, it was followed up for 12 months from pharmacy dispensing data. And what you can see that only 13% of patients over a 12-month period were considered to have good adherence. And that was setting the bar at about 60%. And as you can see, there's all sorts of things that people do. Some of them get one dose of medication and nothing else. And then perhaps they hit a season where their symptoms are being flared up, and perhaps they start again. Some people just have low adherence, and some people have intermittent. With COPD, we find a similar thing. This is the most mild COPD category. This is the most severe COPD category. And as you can see, the dark grey is the one, that shows good adherence. And even in the most severe categories, we have less than half the patients are actually adherent. Another problem that we have in managing these conditions that adds to adherence is the fact that not only do patients have to take their medications regularly, so these conditions are essentially chronic inflammatory obstructive disorders, and they need to be treated regularly. So not only do patients need to take their medication regularly, but they also need to use their inhaler correctly. There's 3 different classes of inhalers, but by the time you put the 3 different classes of inhalers with the different actual drugs in the components, the different doses of drugs, a prescriber has over 250 choices of medications to prescribe. Patients get switched, patients sometimes have more than one inhaler, and there's certainly a lot of confusion. And so it's not surprising when we actually have a look at when patients are taking their medications, however often that is, whether they're actually using them correctly. This graph shows several studies that we and others have done over time, and at the best, we're looking at 30% of patients having correct technique. Unfortunately, most patients perceive their inhaler technique is good or excellent and find their inhaler easy to use. So they're very unlikely to come to us and say, I have a problem with my inhaler and how to use it. If we look at these errors, it's also important to recognize that patients make errors across different devices. It doesn't matter which device. And also that there's actually a very high proportion of patients that make more than one error. So patients can make more than 4 errors. Just as an example, metered dose inhaler, or 33% of patients are making 4 or more errors. And when we think that we can fix these errors, well, we can fix them with education, the right type of education. There are actually different types of errors. So there's errors in preparation for the device, errors in positioning of the device, errors that are associated with the breathing maneuver, and errors that are associated with coordination. So we can fix perhaps the problems that a patient is having with one inhaler, but if they switch to another inhaler, we have to start the whole process again. In fact, we have to recognize that a patient may remember some of the old technique and try and apply it to the new inhaler. And these are things that we really can't change, because these particular characteristics are associated with the particular characteristics, the technical characteristics of the actual device. The other thing that becomes confusing in trying to manage these patients with optimal medication at the right dose, with the right timing, etc., is that patients aren't always started on the guideline recommended treatment regimen. And this is a very interesting study that looked at COPD patients at the time of initiation of their therapy, and it looked at different groups of patients depending on their severity of COPD. And it looked at what proportion of them actually started on medication that was consistent with guidelines. And you can see that actually it's very far from 100%. And looking at this data in a different way, so just even if we just look at the top one, this is looking at the different groups of patients, so in category at least severe to most severe, and looking to see whether their medication changed over time. So this was over a 2-year period, and how it changed. So where you have in COPD, because it's a progressive condition, often patients, if they have a change of medication, you would expect that it would go to the next level up. But what you can see here is that there's actually a significant proportion of patients whose treatment was downscaled. And that's not what we would expect to see. So when we think about a respiratory patient, and I'm putting the COPD and asthma patients together as a concept, because many of these concepts actually are quite similar, what we see is it's very complex. It's complex because we are very reliant on making medication changes based on a patient's disease status. We know that they not only need to be adherent to their medication, but they also need to have correct technique. And the prescriber needs to feel confident that the patient has been both adherent to their regimen as well as technique before deciding whether that treatment is effective. And we know that that is very dependent on the device. So it immediately starts to ask the questions, have we done the right thing by prescribing the most appropriate device for that patient? While we know that there are a whole series of patient factors that are going to impact on that patient's desire to use that medication and their ability to use that medication. Now, unlike, I guess, the renal example that we saw earlier today, and then the hypertension example, patients who have respiratory conditions should be able to tell when they're unwell and when their medication isn't working for them. The other difference is that, particularly with asthma, many of these patients have had this condition their whole lives. So maybe they've had the journey of traveling from childhood, where parents were helping them with their management, to adolescence, to early adulthood and beyond. So they learn to self-manage very well. Should I say, they learn to be in control of what they do. And in fact, they need to be on a daily basis. But that also means that bad behaviors and responses to their condition might be suboptimal as well, and that we need to consider that. So where do we go to from here? One thing that is now becoming more, probably over the last sort of 2 to 5 years, has become very important in our thinking about adherence, inhaler technique, and the respiratory patient, is trying to understand if a patient is not adhering to their medication regimen, is it because they don't know how, or is it because they're actually unable to? One aspect of this is peak inspiratory flow. And this is the amount of inspiratory effort that a patient can actually generate when they're using their inhaler. So when they suck in the inhaler and they want to get a dose with a dry powder inhaler, where it's breath actuated, that is, the patient gets no dose unless they inhale, is the patient actually able to generate that peak inspiratory flow? And what happens if their condition gets worse? Does that potentially mean that when that patient needs that medication most, their lung function isn't sufficient for them to actually get a dose? So these are questions that we have been posing and asking more recently and trying to find the answers. That is, does a patient, what we call, they don't do it or they can't do it? And if they don't do it, then we believe that they have the ability to do it, and we can hopefully solve the problem with training, counselling, etc. But if they can't do it, we need to try and recognise that as soon as possible. And so for this, we're looking at, is there a physiological reason why that individual is not able to adhere to that medication? And this is really where the PIFotal study fits in. I'm not going to go through the outcomes of the PIFotal study because they haven't been published yet, and I'm not sure to what extent I'm able to go into them. But the study protocol has been published, and it's really the first study that looks at patients' ability to use their inhaler as a result of their disease status, looks at their inhaler technique and their medication adherence, as well as their past history of exacerbations. And we actually have found, what I can tell you is that this was done in a group of patients who have COPD, because patients with COPD experience progressively decline in lung function over many, many years, whereas in asthma patients, lung function can recover and they can be very well. A COPD patient's lung function over the years would tend to decline, and so they tend to be at more risk of not being able to use their inhaler. What we found was that in this study, about 30% of patients in primary care, so these were not patients that were visiting a hospital, but just random patients who we invited to participate from primary care, about 30% of them were not using their inhalers correctly, and half of those patients actually were not able to as a result of their lung function. So those particular patients would be candidates for switching their inhaler. Now, it seems very kind of scientific, that decision to change a person's inhaler. But if you think about it in another way, it really starts to be very behavioural as well. If a patient is experiencing shortness of breath or symptoms and they're using their medication and they're not actually getting effect from their medication, that will have implications on their desire and willingness to use or to continue to use that medication. So in respiratory disease, that interplay between experience of symptoms, their perception of symptoms, their willingness, their ability to actually use their medication, use it correctly, really starts to link in. So in a nutshell, to this point, what do we know about adherence interventions? And there has really been an abundance of them done within the respiratory field. And for many, many years, and they have taken all sorts of forms. They have taken a very pragmatic approach, including reminders. They've included psychosocial approaches. They've looked at needs versus concerns, models, all sorts of things. And the conclusion is that the more complex an intervention is, the better the outcome is. When patient factors have been looked at, the most influential factors for improving adherence is the patient's belief about their necessity to use that inhaler versus their concern about using it daily, and their perception, their treatments about the importance of that treatment. There's been a range of new psychotherapeutic behavioural interventions that have started to emerge and been trialled, and a review in 2018 looked at those. They included shared decision-making, motivational interviewing and coaching, etc. And the conclusion was that many of these are still in development, especially when it comes to putting them into practice, but that they hold some hope. And I guess the other thing that I just wanted to mention at some point, no, I might as well mention it now, is that with many respiratory conditions, well, asthma, COPD and allergic rhinitis, they are primarily treated in the community. So these patients are mostly seeing their general practitioner or they're going into the pharmacy. In fact, if we think about patients in Australia, now we have a population of 26 million and about 10% of our population have asthma as an example, and about 8% have COPD. We know that there are 19 million inhalers sold in Australia in 1 year. So that means there's 19 million opportunities for that patient to receive an intervention, but it has to be quick because there's not a lot of time. So, this comes into consideration. Provider-patient communication has also been looked at, and that is effective where that relationship is built on trust and motivation. More recently in respiratory, but more broadly, the concept of how we actually define adherence and whether we use the same taxonomy. It's been suggested that by Bernard Vriens and Rob Horn, I think the gods of adherence, really, that we should all be using the same taxonomy. We should all be looking at behaviours in adherence using the same language across all diseases. And I think there was one more down there. And finally, putting all this literature together, a review in 2017 unfortunately came to the conclusion that it's very difficult to come out with any clear, definitive, most effective interventions because there's so many inconsistencies in measurements, in outcomes. And really, these studies, there is a lot of bias in these studies because, of course, those people who are interested in being in the studies or doing something about it are the ones that are going to be involved in the studies. And I guess that's where our digital health and technologies come into it, which we will look at in a minute. And I should just say, I've sort of been building the case how adherence in the traditional sense of when you take your medication and inhaler technique come together. But in respiratory disease, there is only one tool that actually combines adherence and inhaler technique into one package to be used in practice. So we sort of have clearly struck out as far as that's concerned. Okay, for the remaining few minutes, I'd actually like to bring up mHealth and technologies. And what I'd like to show you is what's been happening with digital inhalers, e-connectivity, and how big data from these digital inhalers and apps has been used to try and understand disease state better. Now, in respiratory disease, we have inhalers that have attachments that are mostly for adherence, and we have then inhalers that have integrated systems that also link to apps. So let's just have a look at some of this. This review in 2017 shows from 1982 the increase in the number of digital inhalers and add-on devices and the increase in capabilities. So all I want you to see is there's a lot happening in this area. One of the studies, I think, and one of the work that I think still is just one of the best sort of studies that has been done was by a group led by Richard Costello in Ireland, where they developed audio technology which time-stamped when a patient took their inhaler, and also they were able to recognize through sound whether the patient actually took their inhaler correctly. And so this is a perfect patient taking it regularly and correctly, but these are all the different scenarios. So from this, they were actually able to see which patients were adherent, which patients were non-adherent, whether they also had good control or uncontrolled disease. And this actually led them to make clinical decisions, whether that person needed to continue what they were doing and be reassessed, whether they could actually have a reduction in dose, or whether if they were uncontrolled but still adherent, they actually were a candidate for increasing the dose. Whereas without this, there's an increase in dose escalation often. Now, showing the patient what their adherence is like and their technique, does that make a difference? So this was a study where this Inca device with the little dots was actually showed to the patient, and it was called biofeedback, compared with just showing a patient how to use their inhaler and counselling them on how, and the control group, which was just standard care. And as you can see, the proportion of patients with adherence of greater than 80% significantly improved in the biofeedback group. And the proportion of patients who had adherence less than 50% was less in that biofeedback group. So what else are some of these digital inhalers doing with e-connectivity? Well, some of these inhalers, and in particular the one that I've shown as an example here, the DigiHaler, actually goes one step further. It does connect to an app, but it is also able to register inspiratory flow. So this is a study that was done in 360 patients, and overall there was 53,000 inhalation attempts. And it actually shows patients who had low inhalation, which probably meant that they didn't get a dose. Those patients who probably just need to be trained to increase their inspiratory flow. And those patients where they may be over inhaling from their inhaler. So this is now beginning to actually give people feedback on their technique while they're using their inhaler. And further to that, research has been done on this inspiratory flow and actually looked to see what the inspiratory flow through the inhaler looks like over time and around when an exacerbation is happening. And they're actually able to pick up a person's change in lung function, as well as the number of inhalations of medication that they're using around an exacerbation. And so ultimately, it's proposed that what would happen is there would be information about the dosing, and there would also be clinical information around lung function. And this together could be used to improve adherence, improve management, improve medication prescribing. Now, some of these devices, just in finishing off, have also been used to actually increase our understanding of disease states. And I'd like to use the MASK app, which has been used, which is essentially a daily diary for allergic rhinitis. And I'd like to talk about some pharmacy data that we're working on. So the MASK app is a very simple app, which is available in 30 countries, which uses a visual analog scale for a person to indicate whether their allergic symptoms, how bothersome they are, from not at all bothersome to extremely bothersome. It covers the nose, the eyes, quality of life, and impact on day-to-day work and activities. So not only can a patient look at what happens over time, but this data has actually been used to try and better understand patients' long-term adherence. It's also been used to develop sort of electronic clinical decision support for healthcare professionals. And most recently, it has been used to identify different behavioural patterns of patients with allergic rhinitis who seem to have different subtypes of disease. So this app is, I just am in absolute awe at the work that's been done with this app, which is now in 30 countries, over 30,000 users, which is actually beginning to shape our understanding of a condition that really we've just sort of put into a big hole and said, everyone who has allergic rhinitis has allergic rhinitis. So I think if you have the opportunity to look at this, it's really worthwhile. I'll just finish with one thing here, and this is some work that we're doing with pharmacy dispensing data. So if you imagine the patient comes into the pharmacy, they've got poor control, poor inhaler technique, poor adherence, the pharmacist has got 2 minutes, they've got to do something meaningful. It's very, very challenging. And even if you're a general practitioner, you probably only have 10 minutes. And that's if you're only dealing with their respiratory condition, which we know doesn't happen. But there's an abundance of data in our data sets. So what can we do with that? We've been working with a company that stores pharmacy data, and what we're trying to do is we're trying to look at patterns of behavior, which with the press of a button, essentially when a person comes and gets their medication dispensed, the pharmacist can get a flag that this person is a high-risk person. And when you, as a healthcare professional, when you actually look at this, so this is for one patient, when you actually start to look at individual long-term history of a patient, and you look to see which medication was started, finished, it's amazing how much you can see. So we are trying to build that into an algorithm, in particular for asthma and for COPD. We're looking at indicators of high risk in terms of particular medications, in terms of timing, in terms of dosing. And we've started to look at whether we can build some heat maps over time, which will also help us to determine if the patient's medications are changing and their severity is changing. And we're even starting to get some signals about whether patients are going from high or low doses in a systematic way. And as you can see, it's not looking very systematic at the moment. So finishing off, in respiratory disease, like everything else, adherence is complicated and it has so many different aspects to it. What we know is that, reminders work for adherence in asthma for those people that have a problem with reminders, with forgetting, but so many people don't. We know that most of these interventions result in some improvement, but it's varied. And some have small improvements, but nonetheless have improvements with regards to regular medication use. We know that eHealth has got great potential. It can help motivate the patients that want to be motivated and better adherence and inhaler technique. But I think we still don't know how to apply this. We know that apps are welcomed by people, at least the people that were involved in these studies, and shared decision-making is absolutely required. But in all of this, we have to remember that it's important for us to keep incorporating real-life data into monitoring because we already have a wealth of data there. And I'll stop that because I've spoken for too long. So I'm really sorry, I get very excited. I can't hear you, Alessio.
So thank you, Cynthia. Your presentation was been great. You have very good highlights coming from this project, and I know very well, and we worked together long time on adherence using on allergic rhinitis, and yes, we discussed long time or for a long time these questions. I will give the door for one or two questions, but one of them, the question that I want to pose you is about how to measure adherence on this case, because you know this question, of course, we have the self-assessment or self-reported scales, but in fact, as you demonstrate here with the inhalators, this question about self-reporting is very, very difficult because, in fact, if they don't take in the correct way the medication, probably is the same of being no adherent.
Yeah.
So,
Yeah.
so how you solve? Because, and I know some of part of your response, how you are using when it comes to real world data, how you have evaluated adherence with real world data.
Yeah.
If you can tell us something about it.
Look, I think a big part of certainly respiratory illness is that patients don't prioritize and think about having to be in good health all the time. So their expectations of how they should feel are probably, they're not as high as what they are for us as healthcare professionals. I think sorting out inhaler technique for me, I think is the easier option, because I think many patients don't use their inhalers correctly because they don't actually realize how sophisticated these inhalers are, what these inhalers are trying to do. And if they're going to work properly, they need to be used properly. So I think an opportunity for a conversation about how absolutely amazing and sophisticated their treatment actually is, which is sometimes in contrast to the messaging. The messaging is, oh, it's very simple, all you have to do is this. Well, actually, they're really sophisticated tools. And so I think that's one part of it. I think the adherence is a long grind. I think the adherence is, there's so many levels to it. And I think for many of the patients that I see, they don't actually realize how unwell they are. And they don't realize that if they actually were to take their medication regularly, they wouldn't have those exacerbations. They wouldn't have those times when they're feeling unwell. I think they simply do not reconsider it. And yes, we know that, others influence the person with asthma, for example, in their decision-making. We know that others do, but the patient has all the control here. I mean, they're the only one that can tell how they're feeling. They're the only one that's in the power to change their day-to-day. I don't think we really have an answer that is a short answer.
Katerina.
Yes, thank you, Cynthia. I really enjoyed your presentation, and actually, I really enjoyed the part that you described how we can develop new habits instead of breaking bad habits, old habits, if I may, habits that don't work actually, and how measurement reactivity can help patients build up their techniques in taking the medications as prescribed, and how that can inform our understanding by observing their behavior. The question that I have is that actually we have recently done a systematic review, and we found that biofeedback is important in terms of addressing those elements. My question is, do you have a hypothesis of whether the behavioral aspects can be addressed by measurement reactivity, and how that is?
Yes, I think there's sufficient evidence with these inhalers and this patient population that if they actually have more sophisticated information and knowledge about their own disease or behavior, it does translate to better use of medications. So the concept of them seeing their lung function, etc., that hasn't really been tested on a large scale yet. But we have definitely, so that Inca study with the inhalers, where they saw what was happening with their behavior, that definitely was superior. And we even, years before that, we used to show them sort of their inhalation maneuver, so they actually used to see what happened with their inhalation on like a spirometry maneuver, and showed how it was different to what they should have been doing. And that was significantly more impactful and effective than what we had previously been doing. So I think we can't actually underestimate the value in giving patients a little bit more technical information or a little bit more sophisticated information about their disease and their medicines. I think that will work for some people.
Thank you.
So we are already out of the time. I must thank a lot of to all of you to take part in this webinar. I must particularly thanks to Cynthia because it's almost midnight in our place. So thank you, and see you next time here in the Beamer webinar. Cynthia and
Thanks.
Katerina,
Nice to
you
see
are
you.
all.
Thank you very much. Thank you.
You are always happy to see you here. You know, in other
Great.
places. Great.
Maybe in real life, not so far away.
Yes, I believe that we will be together very, very soon.
That's good. All right.
Okay.
Thank you. Have a good
Thank
afternoon
you.
and evening. Bye.
Bye.
Okay, it leaves.